Hi everybody, my name's Nat. I'm from Children's Nursing Queensland and I'm a nurse and stomal therapist, and I'm here with Associate Professor Bhavesh Patel, and we're here today to talk about some of the expectations with gastrostomies, and we're talking today about surgical gastrostomies. Dr. Bhavesh, when people are actually having this surgery, what are they actually having? Because I hear a lot of families and doctors and nurses talk about PEGs and gastrostomies, and it can get really confusing when families are trying to find out the right information. So can you tell us a little bit how you actually perform your procedures?
What we're talking about is a gastrostomy. So gastro means the stomach and ostomy means an opening. So essentially what we're doing here is we're creating an opening in the stomach and we're bringing it up to the surface so that we've got a direct access into the stomach. And a lot of people call it PEG. So PEG means percutaneous, as in through the skin, endoscopic, which is one of the techniques to use to put it in, and gastrostomy. So a lot of people call it a PEG. And then people talk about buttons. And so these are the devices that we put in. So that's what we're talking about, is a direct access into the stomach using some sort of a device.
So you bypass all the top half of that gastrointestinal system.
Correct. Yeah. If the mouth can't be used, if we can't swallow effectively, or if it's not a safe swallow, some children have difficulty with swallowing liquids, but they're okay with pureed foods or thickened foods. So whatever the situation is, and if the esophagus doesn't work for whatever reason, then we bypass it and we can go directly into the stomach.
So what can families expect on the day of their surgery? What would typically happen for most of your clients?
So on the day, if they're medically well enough that they don't need to come in the night before, and most of them can come in on the day, is they need to be fasted. So their stomach needs to be empty before having an anesthetic. They'll have a check-in by the nurses in the ward, and I'll come and see them. The anaesthetist will see them, get shown around the ward, and they'll be shown around the day unit, and we come into the operating theatre. Usually someone will come in with them to the operating theatre.
So the parents can go in while the child's falling asleep?
One parent usually goes until they're asleep, and then they'll be escorted out afterwards. Once they're asleep, we go to work.
I think it's really important to note from a nursing perspective, when often surgeons are explaining to families how long they can expect to be under for, there's normally some time either side of that as well. Is it there for anaesthetics and recovery as well? So sometimes it can take a little bit longer in those circumstances.
Yeah. So depending on the situation, often we'll be using a mask with some gas to go to sleep first, and then after that we'll do the drips and things, and then the anesthetic will start. So there might even be a good 10-15 minutes or so, maybe even longer, until we're asleep, and then the procedure starts. And we take our time making sure that positioning is done correctly, and we make sure that we're not lying too much on one particular area in terms of pressure sores, and then we do the procedure. And that usually takes somewhere between half an hour and an hour. And then going into recovery afterwards, that period is quite variable. So sometimes it's a good sort of 15 minutes or so, sometimes it could be an hour. So in terms of from a caregiver point of view, you're away from your child for at least an hour.
And I can see some different tubes in your hands. How do you choose which tube you're going to put into somebody's gastrostomy that you've just made?
So these are two different devices, same brand. Part of it's the discussion we have with the family beforehand. So if you've got a child who has difficulty feeding and is undernourished, maybe losing weight or not gaining enough weight, then I would go for more of an adaptable tube. So I'll start with the adaptable one. So this is a tube that is kind of flexible in terms of its length. So if you think from the point of view of, you've got the stomach wall and you've got your internal tissue layers, you've got muscle, and then you've got the stomach, that distance is the distance between the outside and the top of the balloon. Now that distance is one of the measurement numbers that we use.
And that's centimetres, right?
And that's centimetres, yep. And so What can happen is, as soon as the button's in, now that we've got a really easy feeding mechanism, the child feeds, and even within a 4-week period, they put on so much weight that it becomes too tight if I used a fixed length button like this. So that's the difference. So this is adaptable, this is fixed length. And so once we've reached some sort of stability, then we can use a fixed length button, and that usually needs to be changed every 6 months to a year or so. So you've got the device. This is what they call a button. This is what they call a G tube.
Or dangler's the other term I hear
dangler?
a lot. Dangler's another one.
So this is the button here. So you've got a balloon port, and you've got a balloon port on this one too. Essentially, what you're doing is blowing the balloon up on the inside once it's in, and this is what keeps it from falling out. If you pull on it way too hard, then yes, it can fall out, and that's one of the danger points in the first few months afterwards. But we do everything we can to try and prevent that from happening.
So the balloon holds it in place. Are they also stitched as well?
Some of them are stitched. It depends on the child. So if I've got a child who we are a bit more concerned about whether they're going to grab it and pull it, then I'll reinforce and put some stitches into the button itself to prevent that from happening.
So I can understand there's all these different tubes. You mentioned different brands, different sizes, sometimes stitches, sometimes we do it endoscopically, sometimes it's surgically. I guess probably the big take-home message is when people are caring for these after they've had their surgery, they really need to understand how to care for it safely and properly. So that education piece is really important.
Absolutely. I think that's essential. You can't go into this blind and without any expectations. You have to know what you're getting into.
Excellent. Thanks everybody for listening to us today. If you'd like some more information, you're welcome to reach out. You can find us at Children's Nursing Queensland or Better Kids Surgery on all of the socials. Thank you so much.